Welcome to the assessment of respiratory system in a patient admitted with exacerbation of COPD. Starting with patient summary, Mrs. Aubrey Reading, a 91-year-old female, was presented to the emergency department with worsening shortness of breath and productive cough. Her past medical history include she was a smoker and she stopped smoking 20 years back. She was diagnosed to have moderate dementia, COPD, hypertension, dyslipidemia, type 2 diabetes mellitus, osteopenia, and diverticular disease. She is taking antihypertensives and also she's on insulin for her type 2 diabetes. Her surgical history include she had appendectomy and a left total knee replacement was done in 2012. And she had bilateral cataract removals done in 2005 as well. Coming to her social history, she lives in a nursing home and her husband died 5 years back. She has supportive children living in the same suburb. Her vital signs on arrival to the emergency department was a respiratory rate of 28 per minute. Her oxygen saturation was 84% on room air. Blood pressure was 154 on 63 and a heart rate of 72 per minute, and the temperature at that time was 38.1 degrees Celsius. Aubrey was alert and oriented to place and person but not to time. Patient was not able to talk in full sentences due to her breathing difficulty. Starting with the focused assessment of the respiratory system. The 4 techniques of assessment are used, which are inspection, palpation, percussion, and auscultation. Starting with inspection. The first parameter assessed was respiratory rate and the quality of breathing. The findings were she had a respiratory rate of 28 to 30 breaths per minute and a prolongation of the expiratory phase. Coming to the interpretation, respiratory rate is a significant indicator of variation in the physiological status of seriously ill patients. Aubrey is obviously tachypnic, and tachypnea indicates a low oxygen saturation or a higher concentration of carbon dioxide in the body. Next one is the use of accessory muscles that was present in Aubrey, and this indicates abnormal or labored breathing pattern. And the third parameter assessed was color. So we look for cyanosis. In patients with COPD, we look for central cyanosis. And in patients with central cyanosis, peripheral cyanosis will be present. Central cyanosis will be seen in patients with disorders of the heart and lungs due to the desaturation of arterial blood associated with the shunting of deoxygenated venous blood. In Aubrey, central cyanosis and obvious clubbing of nails were present. Continuing with inspection, the next parameter assessed is the shape of the thoracic cage, and the finding was barrel chest appearance. What it indicates is a hyperinflation of the lungs. In patients with COPD, lungs remain overinflated with air all the time, which increases the anteroposterior diameter of chest wall and makes it barrel-shaped. Barrel chest makes breathing less efficient and worsens shortness of breath. And finally, in inspection, the Hoover's chest sign that was present, and this sign develops due to the inward pulling of the lateral rib cage by the flattened diaphragm. So the diaphragm is staying flattened because the hyperinflated lungs pushes the diaphragm downwards. In chest x-ray we can see it. The diaphragm will appear really flat. Now we are moving on to palpation, starting with palpating the trachea. The trachea was central in position and Campbell's sign was present. Campbell's sign is caused by the downward pull of the trachea by the depressed diaphragm and can be present in any kind of respiratory distress. Next is a range and symmetry of movement on inspiration. It was found that Aubrey had reduced chest expansion and it was symmetrical. This indicates the hyperinflation of the lungs. And the next one is the tactile fremitus. The tactile fremitus was decreased. Again, this is due to the hyperinflation of the lungs due to obstruction in the airways or due to trapped air. That was the three major findings in palpation. Next is the percussion. Percussion finding was hyperresonance. Coming to the interpretation, generalized and symmetrical hyperresonance is a characteristic of COPD. The hyperresonant sounds are created due to the hyperinflation of the lungs with air. So I'm saying about this hyperinflation of lungs in my previous slide too. So let's see what's hyperinflated lungs. Why is this hyperinflation is caused in COPD? It's because of the blockage in the air passages or by air sacs that are less elastic, which interferes with the expulsion of air from the lungs. So the lungs always have air in it and it remains inflated. It's very common in COPD. It's often seen in patients with chronic obstructive pulmonary disease. We are moving on to auscultation, and the findings on auscultation were wheezing, and the wheezing was heard throughout the lungs and airways. What this means is wheezing is usually occurs when air flow through narrow airways of the lungs. In COPD, airways are narrowed due to inflammation. And another finding was crackling, and it was heard with inhalation. Crackles can be heard when small air bubbles pass through fluid, and this indicates buildup of mucus in the airways. And pleuritic friction rub was also heard. Pleuritic friction rubs result when pleural membranes do not slide over each other smoothly. Normally, they are very they don't cause any friction, but in inflammation or in abnormal conditions like this, they don't slide on each other very smoothly, and that results in the abnormal lung sound called pleuritic friction rub. So now we are moving on to additional assessment data, starting with lung function test. So the two major values that are available from the lung function test are a forced expiratory volume of 59% and a ratio, a forced expiratory volume to forced vital capacity ratio of 40%. Both are indicative of severe airway limitation. Usually, FEV1 of 80% or greater is considered normal. 70 to 79% is mildly abnormal. 60 to 69% is moderately abnormal, and 50 to 59% is moderate to severely abnormal. We have also performed a chest X-ray on Aubrey, and that was showing hyperinflated lungs, flattened diaphragm, and a prominent pulmonary artery. The first two findings, hyperinflated lungs, we already discussed in COPD patients, the lungs will be hyperinflated, and that's evident in the chest X-ray. Flattened diaphragm, we discussed that too earlier. And the third significant finding was a prominent pulmonary artery, which is indicative of a secondary pulmonary hypertension. Aubrey also had an ABG done, and in ABG, we all know that there are some other values as well, but I'm just discussing the main three values that should be looked at. That's the partial pressure of oxygen, partial pressure of carbon dioxide, and the pH. In Aubrey, the PaO2 was 83, and PaCO2 was 35, and pH was 7.62. What this means is PaO2 and PaCO2 are within the normal range, even though they are close to the lower limits of normal. A pH value of 7.62 confirms that there is no respiratory acidosis or alkalosis. And then we have also done a complete blood count on Aubrey, and HB was 10.1, and RBC was 5.9. The slightly elevated RBC or erythrocytosis can be a result of chronic hypoxemia. There was actually an interesting study conducted by Zabala and Gazzetta in 2015 concluded that chronic hypoxemia can cause certain compensatory mechanisms in the blood, and erythrocytosis is one among them. So that's it. That were the additional assessment data available for Aubrey at the time I assessed the patient. In order to conclude, Aubrey was diagnosed to have exacerbation of COPD, and the main assessment findings were tachypnea, hypoxia, central cyanosis, barrel chest appearance, hyperinflated lungs, decreased lung capacity, and possible pulmonary hypertension as evident from the chest x-ray, and also erythrocytosis. Aubrey was then admitted to the inpatient medical ward and treated by the medical team and underwent respiratory rehabilitation. Aubrey was ready for discharge on day 11 following the admission, and she went back to her nursing home.